Hello, I'd like to welcome you all to this Red Farm Awards session of the ANZ S&M meeting today. My name is Bridget Chappell and this is my Lindsay Yip, and we'll be chairing this session. The Red Farm Award is an oral presentation of 7 minutes duration with 3 minutes question time, and for those who are presenting, there will be a warning at 6 minutes. So once you hear a ding, hopefully, you'll have 1 minute left to complete your presentation. We'd like to kick off the presentation now with our first speaker, who is Rachel Watherson, who is presenting on the role of nuclear medicine in melanoma, a case study.
Thank you. So my name is Rachel Watherson. I'm from Benson Radiology in Adelaide, and as discussed, I'm talking about the role of nuclear medicine in melanoma, a case study. So the aim of my talk is to examine the role that old and newer nuclear medicine procedures have played in the diagnosis and surveillance of a melanoma patient. The patient in my case study was a 73-year-old lady referred by her GP for a bone scan. The clinical indications provided were previous melanoma, unwell, nausea, general aches and pains, queries spread. Further clinical history obtained from the patient was that a melanoma was removed from her left shin 10 years prior. After administration of 884 megabecs of 99M TC-HDP, whole-body blood pool images were required. Delayed whole-body scans were then obtained 2 hours later, along with a SPECT-CT of the pelvis. The whole-body blood pool images here on the left demonstrate multiple areas of increased uptake in the left inguinal region, which are clearly not seen on the delayed image. On the low-dose CT of the pelvis, lymphadenopathy was noted in the left inguinal region, consistent with blood pool uptake. The largest of these nodes measured 26 millimetres in the short axis, where a normal lymph node measures 10 millimetres. The bone scan report suggested metastatic spread to lymph nodes with no bony involvement seen. It was recommended the patient be referred to a specialist for further investigation. 2 weeks later, the patient was referred to our department for a PET scan after seeing an oncologist. The following information was obtained, and the initial excision was in 2007, a second lesion again removed from the left lower leg in 2008 or 2009. She had received no treatment and had no previous PET scan. She couldn't recall ever having a sentinel node study, though due to the length of time that had passed, she couldn't be certain. Numerous CT scans performed between 2008 and 2012 were all normal, and she had a normal left hip ultrasound in 2015. After checking, the patient had adhered to correct preparation, and with a baseline blood sugar of 5.5 millimoles per litre, she was injected with 189.7 megabecs of 18F FDG. After a 55-minute uptake period, a whole-body scan from vertex to toes was obtained, following by a head, neck, chest, abdomen and pelvis diagnostic CT with IV contrast as requested. The PET scan clearly shows abnormal uptake in numerous lymph nodes, not just in the left inguinal region seen on the bone scan. This image corresponds to the same enlarged nodes seen on the low-dose SPECT-CT. The maximum SUV shown here in distal aortocaval nodes was 47.7. The diagnostic CT displayed enlarged nodes which corresponded with the FDG uptake. There were also carinal nodes that showed increased FDG uptake that weren't yet enlarged on the diagnostic CT. This patient also went on to have an FNA of the inguinal nodes the next week that confirmed metastatic melanoma. I'm sure everyone here has heard of melanoma and has come across this in their professional lives at some point, but I just wanted to touch on some of the statistics, particularly here in Australia, where we have the highest incidence of melanoma. In 15 to 59-year-olds, it is the most common cancer, and in 20 to 39-year-olds, it is a cancer that causes the most number of deaths. Whilst it makes up only 2% of skin cancers, it is responsible for 75% of skin cancer deaths. Melanoma staging, according to the Melanoma Institute of Australia, is from stage 0 to stage 4. Based on the details obtained from the patient and her current and past referrals, we would estimate her initial melanoma to be either stage 1 or 2, as she denied having any lymph node involvement. Many of you may also be familiar with the terms Breslow thickness and Clark score. The Breslow thickness simply refers to the depth from the outer layer of the skin to the deepest portion of the tumour, and the Clark score refers to involvement of skin and tissue. I don't think I really need to discuss too much about why we do PET scans for melanoma patients. PET obviously allows us to visualise metabolic activity in nodes, soft tissue, organs and skin surfaces. Bone scans shouldn't be discounted completely though. They're much more accessible, and not only is it more widely available, but as we saw in the case of this patient, it can also be referred by a GP. The Medicare conditions are not as strict and is relatively cheap and easy to perform when compared with PET scans. However, the benefits of PET are clear, particularly the fact that we use quantitative imaging, so we can assess the patient's response to treatment and give a better indication of complete disease progression, so it has a greater impact on patient staging, treatment and outcome. But back to our patient. All this started because we saw HDP uptake in lymph nodes, so why does this happen? On the early phase of bone scans, we know the distribution of HDP is proportional to blood flow. In those first few minutes, the radiopharmaceutical diffuses out of the blood and into extracellular fluid, proportional to extracellular fluid volume. We see this with inflammation, infection, acute injury, etc. We've already seen that metastatic lymph nodes are increased in size, but we also see increased vascularity, particularly to the cortex of the node. As these metastatic nodes grow quite rapidly, new blood vessels form to supply the nodes, and this is seen as increased blood pooling on the bone scan. So while the whole body blood pool may have been looking for lytic bony lesions, we should remember that bone scans are very sensitive for numerous pathologies and be aware of this when imaging our patients. Finally, I want to discuss the impact that nuclear medicine had on this patient. You might think bone scans are old and boring and everyone's done them, and no doubt we've all seen some interesting things, but it isn't exactly new and exciting anymore. PET is much more new and exciting, and it's a PET scan that has upstaged this patient from a stage 1 or stage 2 patient to a stage 4 melanoma with distant lymph node metastases. However, without the initial bone scan, it is quite possible this patient may not have gone on to have the PET scan, as she wasn't under the care of her oncologist at that time. Without the blood pool images and subsequent SPECT CT of the pelvis, it is likely this scan would have been called normal and the lymphadenopathy not detected. So whilst it may be old technology, it is still extremely relevant and useful, particularly when we use all imaging tools available to us. And if it means the patient is then able to be further diagnosed with newer technologies, it still plays a vital role in the care of our patients. Thank you.
Does anyone have any questions for Rachel? If so, we've got 4 microphones if anyone would like to ask a question. No, Rachel, I noticed that on your preparation for your PET scan, you had that you get the patients to avoid exercise for 24 hours prior. Can you explain a bit about the thought process behind that one?
We're just trying to reduce the FDG uptake in muscles, so just getting them to avoid any sort of strenuous exercise which may then show increased FDG uptake. So we normally just advise patients to take it easy and relax, avoid going to the gym, long walks, that sort of thing. And then importantly, making sure that they're comfortable during that uptake phase, so we're not going to see any muscle uptake.
And also, do you think that this study helps, do you think there'll be a role for blood pool imaging in melanoma patients?
I think I don't know if it will increase the number of scans that you'll get for melanoma patients, but I think it's definitely something to consider. And in our department, it's protocol for us to do whole body blood pools for all melanoma patients that present for a bone scan, as well as a few other pathologies that normally present with sort of lytic lesions, because that's initially what it was done for. And I think it's just more important that the doctors reporting need to keep in mind that they're not just looking at the bones, there's everything else to keep an eye on.
Lovely. If there's no more questions, I'd like to thank Rachel for her presentation.
Thank you.
So our next speaker is Brooke O'Kane from Brisbane, who will demonstrate the potential of lutetium PSMA in patients with advanced castrate-resistant metastatic prostate cancer.
Good afternoon, everyone. My name's Brooke. I'm from the Wesley Hospital in Brisbane, and today I'll just be discussing lutetium PSMA. So what I'll cover today is lutetium-177 therapy for prostate cancer, what prostate cancer is, and how nuclear medicine is involved in the treatment and diagnosis of prostate cancer. So what is prostate cancer? Prostate cancer is an abnormal growth of cells in the prostate gland. Most of the common symptoms include problems urinating, pain, and blood in the urine. So prostate cancer is actually the most commonly diagnosed cancer in men. It's estimated that 3,400 men in Australia will die from prostate cancer this year. 1 in 7 men risk developing prostate cancer by the age of 85, and prostate cancer accounts for 23% of all new cancer cases this year. So the patient I'm going to be discussing today is a 70-year-old male. He was first diagnosed with prostate cancer in 2014. His PSA was 1,400. Initially, he had a biopsy and was staged as a Gleason score 8. The patient went on to have 3 different types of hormone therapy, which actually did stabilise his PSA for quite some time. But last year, his PSA began to rise again, and that's when he was sent to us. So the patient first came to us for a gallium-68 PSMA scan. You can see his PSMA scan up here on the screen. This is the MIP of his PET scan. He has uptake there in his left scapula, left 6th rib, T6 and L4 spinous process. There's also some mild uptake in his prostate. This is the fused imaging from his PET scan, demonstrating those lesions again. And again in the transverse plane. So once the patient had the gallium-68 scan, he was then referred to us for some lutetium therapy. When a patient comes to us for lutetium therapy, we have to assess whether they're actually suitable for the therapy. So how this is done, they have a consult with one of our nuclear medicine physicians. They evaluate the patient's renal function. So if they've got any obstructions, this would actually potentially rule them out from therapy unless there was intervention. If we're not sure if they have any renal impairments, we'll send them for a MAG-3 scan. If there's no evidence of an obstruction, they then move on to a gallium-68 PSMA scan if they haven't already had one in the last 3 months. From this gallium-68 PSMA scan, if there is evidence of a PSMA-avid metastatic disease, we will then move on and say that yes, they are suitable for PSMA lutetium therapy. So when the patient first arrived to us for his therapy, he arrived having done a 3-hour fast. He was well hydrated. We got him changed into a gown and prepped him with the radiation precautions that he would need to follow. An IV cannula was inserted into his cubital fossa, and he was medicated with Zantac and Maxilon. We also administered 500 mils of lemon water diluted and 500 mils of normal saline through the drip, just to ensure that the drip is patent and working. So we actually make the lutetium PSMA on-site in our lab using the Eckert & Ziegler Modular Lab Easy. We purchase the lutetium from Ansto, and this synthesis is pretty straightforward, taking about 33 minutes to complete. Quality control is also done on site. We use the Eckert & Ziegler HPLC and TLC units. So the mechanism of uptake for PSMA, it's a cell surface membrane which can be expressed as a GCP2. Prostate cancer cells have an increased expression of this GCP2, which means that they'll just have a higher increase of the tracer uptake. So for the patient's first therapy, he got 4.6 gigabecquerels of lutetium. This was given through his cannula using our RAD-inject system, which is pictured up on the screen there. It's a 10-minute infusion of the lutetium, followed by 2 7-minute saline flushes. Immediately post-therapy, we give the patient a litre of normal saline just to ensure they're well hydrated, and 40 milligrams of furosemide as a bolus, just to stimulate the kidneys to kind of get rid of any excess lutetium. We also do a whole body and SPECT CT 4 to 6 hours post-infusion of therapy to check the uptake of the lutetium. So here is a picture of the patient's whole body done on our Siemens Symbia T16 SPECT CT. You can see there that the patient has uptake in the previously identified metastases on his PET CT. Here's the SPECT CT images demonstrating those lesions again, and again in the transverse plane. Now up on the screen we have a comparison of the patient's first PET scan compared to the whole body of the lutetium therapy. In the comparison there you can really see that the lesions have taken up the lutetium perfectly. Across the top line there, we've got his fused images from his PET CT compared to the bottom line, which is the SPECT CT of the lutetium therapy. Again, you can see the image quality of lutetium is quite good on the gamma camera. So before we can discharge the patient, we ensure that we are following the ARPANSA guidelines for therapeutic patients. They have to be below 25 microsieverts per hour at 1 metre. We measure the patient with a handheld Geiger counter each hour to ensure that they are at this level. So the patient came back to us for treatment too. It was 6 weeks after his initial treatment. This time he got 4.5 gigabecquerels. This here is his whole body scan from the second treatment. Again, you can see it taken up in those lesions. SPECT CT data again from his second treatment. And here's a comparison. You can see in the second treatment on the right there that the uptake is less in the treatment too. So what does this mean for the patient? We have his, how do I go back? PSA levels there. So before treatment 1, his PSA was 9.8. After treatment 1, we got it down to 3.8, and then at the end of treatment 2, we got it down to 2.8. So this was a 71.4% drop in PSA. This was pretty good considering that the German multi-centre study that was published last year stated that for a treatment to be deemed successful, the patient should see a drop in PSA greater than 50%. So for this patient, lutetium therapy was proved to be pretty beneficial. So what's next for the patient? He'll have some more treatments.
Brooke, you might just need to
Yeah, this is the
up.
last slide, thanks.
Okay.
He'll have some more treatments and he will be monitored closely by his oncologist. He'll also have a gallium-68 PSMA scan to evaluate whether the treatment has worked. Any questions?
Just a quick question.
Yeah.
Besides the biochemical markers,
Yeah.
were there any quantification of lutetium uptake or therapy response based on your whole body scans?
So we don't actually use the whole body scans on the gamma camera to evaluate whether the treatment's working. It's more so the PET scan. So that's why they have a follow-up gallium scan 6 months after commencing treatment. The doctors actually use that as a visual tool to evaluate whether it has worked. This treatment, this patient actually has had his follow-up gallium scan since when I did this presentation, and he's actually had 2 of the 4 metastases have a complete resolution, so pretty promising for the therapy.
Thank you.
Yeah.
Any other questions from the floor?
Thank you, Brooke.
Thank you.
So our next speaker is Kim Jasper from Victoria, who will be speaking about a case study to illustrate the usefulness of technetium PIP to image cardiac amyloidosis.
Thanks, guys. Amyloidosis is a relatively rare disease where the extracellular deposition of insoluble proteins, known as amyloid, can cause systemic effects. In the heart, it can lead to cardiac amyloidosis, where the ventricle walls become thick and rigid, which leads to decreased ventricular filling. There are many different types of amyloidosis, which have quite varied treatments, and so it is essential that the correct diagnosis is made. For cardiac amyloidosis, this has historically been by way of a cardiac biopsy, which is quite an invasive procedure, and so a non-invasive imaging-based test is preferred to differentiate between the different subtypes. The aim of this case study is to demonstrate how a 99-MTC pyrophosphate, or PYP scan, was used to diagnose the correct subtype of cardiac amyloidosis and how this impacted on the patient's management. A 74-year-old male presented to the emergency department at Knox Hospital in May 2017. He'd had increasing shortness of breath on exertion, lethargy, long-term tachycardia, as well as joint pain and lower leg edema. He'd had intermittent chest pain for the last 3 years, for which he'd had an angiogram in 2014, which showed negligible disease. He'd had several hospital admissions since then, but in the words of the patient, no one seemed to be doing anything about his worsening condition, and so he decided to cease all of his prescribed medications in January 2017. His other risk factors are noted. A chest x-ray was essentially normal, but an ECG showed left heart strain, and so he was referred for an echocardiogram. This showed an EF of 48% with moderate to severe left ventricular thickening with the appearances of infiltration rather than hypertrophy. With a repeat angiogram planned for the following day, the doctor then referred him for a 99-MTC PYP scan for query cardiac amyloidosis. 99-MTC pyrophosphate has historically been used in nuclear medicine for infarct-avid or hotspot scanning. It was administered to patients after a suspected heart attack, as acute myocardial uptake is seen in the 24 to 72 hours after an acute myocardial infarction. This was due to the phosphate being attracted to the increased concentrations of calcium present in the myocardium after an infarction. For those in the audience who have not seen these scans previously, here are some examples from a textbook, as there were no image files available at Knox Hospital. Throughout the 1970s and 80s, there were incidental findings of myocardial uptake on methylene diphosphonate bone scans, which were confirmed to be cardiac amyloid on biopsy. The mechanism of uptake is unclear, but it is thought to be related to high calcium levels present in tissues affected by amyloidosis. In 2013, a new phosphate-based tracer called 99-MTC-DPD showed increased myocardial uptake in patients with cardiac amyloid. This tracer was not readily available in the USA, and so 99-MTC-PYP was investigated as an alternate tracer. This showed promising results and led to the American Society of Nuclear Cardiology releasing their practice points outlining the use of PYP in diagnosing cardiac amyloidosis. Following these guidelines, we administered 720 megabecquerels of 99-MTC-PYP IV, and we acquired several statics around the chest 1 hour after injection on our Antivo gamma camera using the following parameters. SPECT-CT was also performed to remove the bony overlap of the shoulders and the ribs and assess the tracer distribution. A whole body sweep and repeat statics and SPECT-CT at 3 hours post-injection may also be acquired. The static images showed increased uptake throughout the myocardium on all views. The SPECT images also showed uniform uptake of the PYP throughout the heart muscle. As per ASNC guidelines, we also performed quantitation on these images with an ROI drawn around the heart and the contralateral chest to calculate the ratio. The ASNC states that a ratio of greater than 1.5 is indicative of TTR cardiac amyloidosis, which is a specific subtype. This patient had a heart to contralateral chest ratio of 1.7, meaning that it was a positive test for this type of cardiac amyloidosis. Amyloidosis is a relatively rare systemic condition. It has no cure, and so treatment is restricted to easing a patient's symptoms and preventing further amyloid deposits throughout the body. This can include special diets, as well as a variety of pharmacological options. There are more than 20 different subtypes of amyloidosis, each with differing treatment options. The main two types are known as AL and ATTR. AL, or amyloid light chain, is where immunoglobulin light chains, which are produced in the plasma cells of the bone marrow, become misfolded and are deposited around the body. There is no genetic component, and it is usually diagnosed by blood or urine tests or a bone marrow biopsy. Due to the abnormality originating in the bone marrow, it can be treated with chemotherapy. ATTR amyloidosis involves the transthyretin protein, which transports thyroxine. The usually tetrameric protein becomes unstable and is deposited around the body. There are two main subtypes. Mutant TTR is where there is a genetic link and a mutation on the TTR gene. These patients will usually have a blood relative who has been previously diagnosed with amyloidosis. This is in comparison to wild-type TTR, which has no genetic mutation and indeed no known cause. Because of this, it can be quite difficult to diagnose, but it is more common in older white males. With cardiac amyloidosis, it usually presents as an infiltrative cardiomyopathy, as the amyloid deposits have caused the ventricle walls to thicken, causing the patient's symptoms of heart failure. It can often mimic other heart conditions, such as hypertensive heart disease, and so it is important to differentiate between this and cardiac amyloidosis to ensure that the correct treatment is prescribed. This case study patient showed signs of heart failure clinically and on his ECG, and an infiltrative signal on his echo, leading the clinician to suspect cardiac amyloidosis. The nuclear medicine pyrophosphate scan was positive for TTR cardiac amyloidosis, but the patient had no genetic history of the disease. Thus, he was diagnosed with wild-type TTR cardiac amyloidosis. Following this diagnosis, he had a pacemaker inserted and was prescribed digoxin and Bicor and returned for review a few months later. So in conclusion, a 99 MTC PYP scan was instrumental in the diagnosis of this patient's wild-type TTR cardiac amyloidosis. In a patient with no family history of amyloidosis, it allowed for the correct treatment to be administered, leading to the best possible quality of life in a patient with this non-curable condition. Here are my references, and I'm happy to take any questions.
Do we have any questions from the floor for Kim? Yep, if you just come down to the microphone. Just so everyone can hear your question.
Can I just ask why you're not doing the 3-hour imaging?
Because we are mainly following the ASNC guidelines. This was the second patient we'd done in the department with cardiac amyloid, and so we were following those guidelines fairly closely. They state that 3-hour imaging is only necessary if you don't have good clearance of the blood pool at the 1-hour image, which can often happen in patients with amyloidosis, because if they've had renal failure or secondary to their amyloidosis, you won't get that clearance of the tracer at the 1-hour scan. This patient did have good clearance. We got nice visualisation of the heart, and so a 3-hour scan wasn't necessary.
Thank you.
Thank you.
Any other questions? Yep.
Hi, Kim.
Hi.
My question is, do you routinely do whole body scans on this, and if so, what is the benefit of doing a whole body scan?
Sure. We didn't specifically do one on this one. As I said, this was our second case. The ASNC guidelines state that whole body imaging is not necessary for diagnosing cardiac amyloidosis. However, it is actually helpful in diagnosing systemic amyloidosis. So since this patient, we have actually instigated whole body scanning at that 1-hour mark to sort of get an idea if there is any systemic amyloidosis. You can see uptake in the shoulder and hip girdle if they have sort of got a bit of a systemic condition going on. So with this patient, we sort of, we could see in that first image that it was a positive scan. So we're like, well, the clinical question's answered. We didn't think, we needed to do the whole body, but in further discussions, we have added as part of our protocol and is standard for all of our scans now.
I've got a quick one.
Yeah, thanks.
This morning they spoke about the role of follow-up imaging in terms of disease progression and early intervention. Do you know if there's any plan to follow up any of the amyloid patients you've done as such?
We've done a handful so far. I followed up this one because it was part of my case study. Most of the ones we've had so far have been positive. We have had a few negative, but we haven't sort of had any patients that we've able to come back and follow up. I think because a lot of the patients that we see are sort of this wild type, the doctors go, all right, well, we'll just sort of treat the cardiology side of it rather than, worrying about the systemic effects. A lot of the bigger hospitals that would have, an amyloidosis patient group, they're probably going to look at follow-up going on further. So no, we're usually the guys that have come down from CCU or whatever, and they need to sort of figure out what's going on with them. So no follow-up as yet. As I said, we've been doing this for about a year now. We've probably done maybe 8 or 10 patients. So it'll be interesting to see if we do get some coming back in the future, and we'll be able to do some of that quantitation that we saw this morning, which I'm going to take back and start looking at.
Lovely. Okay. Well, thank you.
Sorry, I just was wondering, just one more quick question if I can.
Hi.
Well, hello. What's the method of reconstitution of the PYP vial?
Oh, I'm so glad you asked. The first time, the first request that came down, we actually had a mad rush around the department trying to find the reconstitution details. In the end, we ended up calling Tullamarine Radiopharmacy. Anyone in Melbourne knows they're the guys who are to speak to. They couldn't find any information. So basically, between the two of us, we put it together 2 gigabecs in 5 mils, add it to your PYP kit that would use for your gated imaging tagging, wait 10 minutes and off you go. So I don't know, I hope there's not a rep in here anywhere who's saying you shouldn't be using it for that, but that was what we sort of did. We spoke to the senior radiopharmacist and figured out that was kind of the best way to go.
Okay, thank you.
Thanks.
Thank you very much, Kim.
Nice.
Thanks. I'd now like to welcome to the stage our next Red Farm presenter, Ms. Cassandra Tran, with her case study, Amyloidosis, the Cardiac Scan, a case study in transthyretin amyloidosis. ATTR.
Hello everyone. For those who don't know me, my name is Cassandra and today I'll be talking about a case study on amyloidosis cardiac scanning. Cardiac amyloidosis is an infiltrative and complex disease characterized by deposition of amyloid fibrils within the heart, leading to progressive thickening of the walls of the heart. There are two subtypes of amyloid that commonly infiltrate the heart: immunoglobulin light chain amyloid, or AL, and transthyretin amyloid, or ATTR. Cardiac retention of 99M technetium PYP has been demonstrated in ATTR patients. ATTR can be either familial amyloid cardiomyopathy or mutant type and senile systemic amyloidosis, or wild type. Differentiation between AL and ATTR amyloidosis is a critical factor to treatment due to the differing clinical courses. The current gold standard is cardiac biopsy, coupled with immunohistological staining. As an invasive procedure, there is a need for the development of a non-invasive imaging modality that can differentiate between the two subtypes. This is where nuclear medicine cardiac scan holds great potential as a non-invasive imaging modality. A scan that was performed on a 75-year-old male in severe heart failure demonstrates the utility of nuclear medicine as a diagnostic modality. A recent echocardiogram demonstrated thickening of the walls of the heart. Here is a still image of the echocardiogram of the heart. There is thickening of the septal wall due to amyloid infiltration. Additionally, there is a bright speckling appearance of the heart, which is suggestive of amyloidosis. Transthyretin is a transport protein primarily expressed by the liver. Mutant-type amyloidosis exhibits an autosomal dominant pattern of inheritance. These mutations cluster into geographic or ethnic groupings. Wild-type amyloidosis arises sporadically and is caused by misaggregation of transthyretin that causes fibril formation. There is no curative treatment for ATTR cardiac amyloidosis. ACE inhibitors and diuretics may be used to improve forward cardiac flow and renal perfusion. Orthotopic liver transplantation can eliminate circulating levels of mutant transthyretin. However, in patients with pre-existing cardiac amyloid involvement, the cardiac condition continued to worsen. There was no patient preparation for the scan. The patient was injected with 847 megabecquerels of 99M technetium labeled PYP. Scanning was performed at 1 and 3 hours post-injection. At 1 hour post-injection, an anterior posterior static of the thorax was taken for 5 minutes, followed by a SPECT CT of the same area. At 3 hours post-injection, the same static of the thorax was taken, followed by a whole body sweep for 12 centimeters a minute. Cardiac retention was assessed with quantitative analysis. The mean counts in the heart region of interest over the mean counts in the contralateral chest are defined as the heart to contralateral ratio, or HCL. In this patient's scan, there is intense tracer uptake in the left ventricle and low to moderate diffuse tracer uptake also present in the right ventricle. The HCL ratio score is 2.2, consistent with ATTR amyloidosis. Here's a comparison of a negative versus positive scan for ATTR. Using another bone-avid compound, 99M technetium DPD, a study done by Rapezzi et al. On both ATTR and AL patients, tracer uptake was found in 1/3 of AL patients. A differential diagnosis can still be determined, however, only in cases of absent or intense uptake. Whilst echocardiography is considered a standard investigation, it is not etiologically informative. This case study highlights the opportunity for nuclear medicine to become a key diagnostic modality for differentiating between AL and ATTR amyloidosis. 99M technetium labeled PYP is already a commonly used radiopharmaceutical for nuclear medicine scans such as gated heart pool scan. Due to the accessibility of PYP, amyloidosis cardiac scan has significant potential to be performed more widely. Nuclear medicine has played a pivotal role in the diagnostic pathway of this patient. Even though a diagnosis of ATTR amyloidosis was determined, due to their terminal stage at presentation and the fact that the patient was already on the appropriate symptomatic treatment, there was no overall change in patient management. However, this scan could significantly beneficial to a patient in the earlier stages of disease. As a potentially fatal disease, identification of the subtype is crucial to treatment management and could result in a better prognosis for the patient. By reaching a positive scan result, this gives the patient an answer to their deterioration, in which previous investigations have not found a conclusive answer to. Additionally, it removes the need for other invasive investigations such as cardiac biopsy. An important outcome of this case study is that considering ATTR can be inherited, a positive scan outcome may warrant genetic testing for family members. A heart to contralateral ratio score of greater than 1.5 is associated with 97% sensitivity and 100% specificity in differentiating subtypes. Therefore, amyloidosis cardiac scanning can not only detect cardiac amyloidosis, but can provide a differential diagnosis with a high degree of certainty. This case study truly highlights the unique value of nuclear medicine as the only non-invasive modality for differentiating such a diagnostically challenging disease. Thank you.
Do we have any questions from the floor? No, it's a topic that's been widely covered today, but I do have a question for you. I'm just wondering whether you noted there were any difference in the normal thoracic region activity to heart uptake between the two different time points that you scanned, between the 1 hour and 3 hour? Was there any variation at all?
No, there wasn't much variation. In practice, quantitative analysis and visual scoring is based off the 1 hour study. Data has found that uptake of ATTR specifically is better imaged between the 1 and 3 hours. And traditionally, when PYP was used as an adjunct for diagnosing myocardial infarct, it was imaged around about 1 hour.
I just have one question. You mentioned in your conclusion that this imaging might benefit a patient in an earlier stage of disease. Do we know if a patient who's in the earlier stage of disease will have a different ratio of heart to contralateral lung ROIs?
Yes, so ATTR is a very insidious disease and has a very slow uptake compared to AL, which has a 50% mortality within 6 months of diagnosis. So usually most patients that we've had an image are in the later stages of disease just because of such difficulty in diagnosing their symptoms, which are very similar to other cardiac conditions such as sarcoidosis and unstable angina. But I imagine that there would be similar uptake, yes, as in greater than 1.5 for a positive scan.
Thank you.
And I think we've got one more question from the floor.
This is made based on the planar regions on the planar imaging. What is the value of the SPECT-CT?
So the value of the SPECT-CT that we use is to assess the myocardium, it's a 3D image essentially, to see if there's any signs of infarction. Also, it gives a more sort of accurate representation of disease because of the overlying physiology, such as the bones. And of course, there is a lot of blood pool uptake in the ventricles, so SPECT-CT is valuable in clarifying that.
All right, thank you very much, Cassandra.
Thank you.
So our next speaker is another Cassandra Crudella, who will be illustrating the utility of subtraction SPECT-CT in parathyroid imaging.
Okay, so I'm coming from Western Australia in Sir Charles Gardner Hospital, and this is a lot more people than I was expecting. So, yeah, you came. Okay. So, dual isotope imaging in subtraction SPECT-CT in parathyroid imaging. By the end of this presentation, you should have a greater understanding of dual isotope parathyroid imaging, both in planar and SPECT-CT, as well as the importance of dual isotope parathyroid imaging as part of a multidisciplinary treatment team. The patient, a 49-year-old female with biochemically confirmed hyperparathyroidism with a parathyroid hormone level of 20.7, was referred for localization of a parathyroid adenoma. With the prevalence of blood testing, most patients are asymptomatic upon diagnosis of hyperparathyroidism. An elevated parathyroid hormone level of a patient with hypercalcemia is diagnostic of hyperparathyroidism. Primary hyperparathyroidism is the third most common endocrine pathology, with 85% of patients presenting with a solitary parathyroid adenoma, and it is most common in postmenopausal women. Parathyroid imaging studies are a secondary tier of diagnosis. Subtraction imaging was first used with thallium and technetium pertechnetate. The thallium was soon replaced with technetium-99 sestamib due to its more desirable imaging attributes. Iodine-123 overtook pertechnetate as the thyroiding image. Iodine-123 has a small increase to the radiation burden of the patient by 43%, but the accuracy and localization of the parathyroid adenoma makes this more beneficial. The dual-phase image method using sestamib depends on the washout of the sestamib from the thyroid, but retention in the parathyroid adenoma. This pattern occurs in 70 to 75% of patients. In the remainder of patients, the parathyroid adenoma washes out at the same rate as the thyroid tissue, and thus in solely dual-phase method, this goes undetected. Dual imaging using subtraction is slightly more complex in the post-processing, but the advantage is perfect co-registration and a decrease in patient imaging time and discomfort. The data is simultaneously acquired under 2 photo peaks, 159 kV for iodine and 140 kV for technetium. Windowing is utilised in order to combat downscatter from the iodine, however, cross-contamination of the photo peaks is unavoidable. The mixture of photons from 2 sources and standard reconstruction is used in the SPECT generally leads to an image that is degraded in quality and quantitative accuracy. The patient was administered with 29.1 megabecquerels of 123 iodine orally 3 hours before imaging, and 754 megabecquerels of technetium sestamib immediately prior to imaging. Both imaging photo peaks were acquired and placed into 2 separate data sets to allow the simultaneous imaging. The image in the top left is the 123 iodine, and on the top right, the sestamib. Then you can see there is an increase in activity in the sestamib seen in the lower pole of the right thyroid gland, which is not present in the corresponding iodine image. No ectopic parathyroid tissue was seen. The removal of the thyroid uptake in the subtraction planar set in the bottom right confirms the discordal uptake. The range of subtraction data is displayed to prevent the introduction of artifact from over or under subtraction. The central subtraction at 17% is a true display of the removal of the thyroid tissue and clearly demonstrates the parathyroid adenoma. Subtraction SPECT-CT offers the advantage of better anatomically defining and localizing of the parathyroid adenoma. Using the data from both the sestamib and the iodine SPECT, we are able to apply the subtraction to the SPECT data and the overlaying this corrected data to the CT and processing it as normal, allowing us to see a subtraction SPECT-CT. Through the SPECT-CT images, you can see that the uptake is split into 2 adjacent foci. The more posterior focus localizes in the nodule of the posterior and inferior of the right lower pole of the thyroid. The more anterior focus is difficult to separate from the posterior aspect of the thyroid, and it's recommended that we have correlation with ultrasound to exclude a thyroid nodule. Hyperparathyroidism is predominantly treated with surgical intervention. The influence of medical imaging has seen surgical change from a bilateral surgeonotomy with 4-gland neck exploration to guided, focused approaches. Perioperative localization enables minimally invasive surgical techniques, and they're also critical for patients with prior neck surgery or recurrent post-operative hypocalcemia. Because of the distortion of normal anatomical landmarks, and the increased incidence of ectopic adenomas. Our patient underwent surgery and the parathyroid adenoma was removed and a parathyroid hormone level dropped from 22.9 pre-surgery to 3.3 2 days post-surgery. The patient has had follow-up blood tests with no rise in the parathyroid hormone levels. Looking forward, SPECT-CT acquisitions to localise and detect adenomas. It provides critical information when choosing the most suitable surgical access and limits surgical exploration and avoids recurrent laryngeal nerve injury, which is a risk during this type of surgery. Due to parathyroid scintigraphy's ability to identify and localise ectopic parathyroid tissue, it will remain part of the pre-surgical workup. Nuclear medicine is a critical part of this patient's road to a speedy recovery and for all other patients with parathyroid adenomas. My wonderful references. And are there any questions?
Any questions from the floor? Yep.
Can you tell me how difficult it is to get access to iodine 123?
In my hospital, we're actually really lucky. We're able to get it in quite easily. We have a wonderful radiochemist who just puts in orders. So I'm not quite sure exactly how we get ours, but I do know for centres away from major cities it is quite difficult and quite expensive to get. Yeah, for us it just comes on a truck.
And is that weekly, daily, monthly?
We try to group our patients, so we will do a parathyroid adenoma as well as workups for patients who are going on to or who have previously had iodine 123 treatment. So we try and get them in a group lump sum, and so we have a 1 weekly delivery. Sometimes it might be one every fortnight, depending on how many patient numbers we can get.
Thank you.
Okay.
Second question.
Have you looked at the SESTA-BIBI data just by itself and tried to work out what percentage of the population is the iodine is useful for the scans, like it was necessary?
I haven't looked at the SESTA-BIBI data itself. However, from my research, it was the 25 to 30% of patients that have the adenoma wash out at the same rate. On those scans, some of the physicians that do report on those scans can make determinations of a parathyroid adenoma by the discrete amount that's still left in that adenoma. But for any adenoma that has that true washout at the same rate as the thyroid tissue, there is just no way to detect it. And that's why the dual isotope is so much more preferred, because it eliminates that as a potential false negative.
Cassandra, I can just clarify, did you mention that iodine was given orally or intravenously?
Orally.
And how was that administered?
We take them through to our hot lab and we just have a little glass of water that we have put the iodine into. They pop their hands behind their back and they drink it out of a straw like bobbing for an apple, which is, yes, what I tell every single patient when I tell them to do it. Yeah, so it's just done in the lab and we send them off for that 3 hours and then they come back.
And also, Cassandra, with the oral intake of I-123, do you get the patients to fast or anything to help sort of speed up the uptake, given that you're imaging sort of a couple of hours or 3 hours later or 2 hours later or whatever?
No, we have no preparation for that iodine uptake. Because we only need a small amount to be in the thyroid, we're not too concerned. We don't give them a low iodine diet or anything like that to promote that uptake, because iodine is so avid in the thyroid just generally, we don't need to take any extra precautions, or at least we haven't found the need to.
Right. Thank you, Cassandra.
Thank you.